Okay, so when last we left off, we were talking about AP toes. Correct me if I'm wrong. I think that's where we left off. So next on our list is going to be the oblique toes. So whenever we do our oblique toes, we're going to do a medial rotation of the foot. And it's very important because whether we're doing a foot or toes, we always opt for a medial rotation. We wouldn't do a lateral rotation. Now you will notice when we do a medial rotation on the toes, there would be some of the toes that have a little bit of OID, specifically really 2 through 5 would all have a little bit of OID. That's considered acceptable because we still want to opt for that medial rotation to properly open up those joints. The only time we would ever do a lateral rotation would be if it was a specialized exam ordered by the doctor. But with Harris Health and really anywhere else I've ever seen, that's why it says HHS right here, by the way, Harris Health System. For Harris Health and any other facility I've at least ever worked at, we've always done the medial rotation on the toes, even though there's going to be a little bit of OID if we're focused on toes 2 through 5. So put it in your head, whether we're talking about toes or feet, that's always going to be a medial rotation. And that's going to be a range of 30 to 45. In this case, 45 would always work. I always use a 45-degree oblique. I say, remember one number when you have a range, stick with the 45 because that's the one that you're familiar with. SID will be 40 inches, just like everything else we're talking about this semester. And your CR is going to be a perpendicular ray. That's different from the AP. Make sure you remember that. When you do your AP toes, you're going to have an angle on your tube. When you go to that medial on the toes, you're actually going to remove the angle. It's going to be a perpendicular beam entering at the MTP joint. And that's going to be specific to the toe we're talking about, by the way. So if I'm looking at the first toe, that would be the first MTP joint. Second toe, second MTP joint, third, so on and so forth. That's not just going to be right in that middle MTP. It's whatever toe that we're focused on. As far as the IR size, it would be an 8x10 or 10x12 landscape. Collimation, like I said on Friday, collimation is going to be extraordinarily important on toes because toes notoriously become very, very burnt out on x-rays. So the more tight collimation we can get on those toes, the better those images are going to look overall. If I leave that beam wide open, those toes are going to get very black on the x-ray. And you'll notice on a lot of foot x-rays, since you have the collimation a lot wider, because you're getting the entire foot, those toes start to turn really black and burn out. So when we're specified on the toes, that close collimation is key to getting a very nice image. Tabletop, this would always be done tabletop. We're not ever going to do this in the bucky. Always tabletop for all your toe x-rays. And of course, gonadal shielding. Now you will notice here in the picture on the left, they are using some tape to pull these other toes out of the way. So depending on what toe you're looking at, and you need to look at your patient's feet. If you notice a patient has a lot of toes that are overlapping on top of each other, they're really gnarled, curled looking, you're going to want to opt for trying to pull those toes out of the way. Now sometimes they can use their hand to pull the toes out of the way. Sometimes they need to use tape like you see in the picture there. Main point is get the toes out of the way and make sure you're focusing on the one toe of interest. Now, sometimes they'll order all the toes. You can just get them all in a fan view on that oblique or AP or whatever. But if they're wanting just one toe, make sure you move the other toes out of the way because they can obscure what they're trying to see. You will notice they put their marker upside down on that x-ray. Don't do that because we hang the toes up on our x-rays.
Mr. Donnie, did you say the medial rotation test specific for Harris Health? And all the toes are medially rotated?
So as far as Harris Health, yes, it's always medial rotation. Yes, that's what we want you guys to do is medial rotation.
Okay, but like
for every toe.
Okay, if we got a question like this on let's say the registry, would it be the same thing, or would we have to know like 4 through 5 laterally for like registry?
The most accepted form for toes is always medial. Lateral would always be a special request.
Gotcha.
Yes, so it's always going to be medial rotation unless otherwise specified by the radiologist.
Okay, thanks.
But Harris Health in particular will never opt for lateral rotations. So. Okay, our evaluation criteria for oblique toes. We want the digits in the minimum of the distal half of the metatarsal demonstrated. So it's very similar to that AP toes. In fact, it's the exact same criteria. We're not so much interested in the metatarsals. We only want the distal half of them to show. And that's because the way the toes are positioned on the foot, the main star of our radiograph is that proximal phalanx all the way into that distal phalanx, because we are centered right at that MTP joint of the corresponding toe. So we want this MTP joint, which I have the cursor on right here, that needs to be in the center of your radiograph. It's the main area of centering. And the main star, once again, is the proximal phalanx to the end of that distal phalanx. We do want the IP and MTP joints to appear open. When it says IP, it's not just talking about the big toe, it's talking about the PIP and DIP as well. It's just saying all the interphalangeal joints need to be open, and also those MTP joints need to appear open as well. Increased concavity on one side of the shaft. That's talking about this little curve right here. We want that to look like a nice C. And that tells us that we have that foot in a proper 45-degree oblique right here. Head of the metatarsals not overlapped as much as possible. Once again, that will confirm that we have that foot in the proper position of 45-degree obliquity. If the head of these metatarsals are not overlapping on top of each other, if they are, that means that we did not oblique that foot enough. And of course, our optimal exposure factors. And do keep in mind, anytime we talk about obliques in radiology, the main reason we're doing obliques as far as extremities are concerned is to open up joint spaces. That should always default in your mind. When I do an oblique for an upper or lower extremity, I'm opening up joint spaces. That's the main reason. And once again, you'll see here, it's the same for the PA. As long as you got the corner of your marker in there, that's fine. You don't have to have the entire marker in there because you are using super tight collimation. So we understand that your whole marker may not necessarily fit in there, but that collimation is so vital. If we don't have this tight collimation like we see right here, these toes get very black. Can't make out the little details. Okay, so for the laterals, for a lateral first digit, you'll notice right there on the picture, once again, one thing that they're doing is they're pulling those other toes out of the way. I believe you guys probably learned this way in lab as well, using your hand to pull your other toes out of the way. Very important we get those other toes out of the way, because if we do not, the toes are all superimposed on top of each other, and we don't want that for lateral toes. Now, when we're talking about a lateral foot, not so much a big deal, because we're looking at the entire foot. We're not really focused on the toes. But for toes in particular, we must move those toes out superimposition. So depending on what toe we're looking at in the lateral position, we do need to make sure we isolate that one toe and pull the other toes out of the way, completely out of superimposition. So this is a little different than the oblique. If you remember on the oblique, we did everything as a legal oblique. But for laterals, we're going to turn the foot in a different direction depending on what toes we're looking at. When we look at laterals for toes 1 through 3, we're going to do a lateromedial projection. That means the lateral side of the foot is up, the medial side is touching the film, which we see right here. If we're looking at toes 4 through 5, we're going to do the opposite, a mediolateral projection. Put a big star on that because it's really easy to forget. Toes 1 through 3, we do a lateromedial projection. Toes 4 through 5, we do a mediolateral projection. And the purpose of that is to try to get that toe as close to the film as possible to reduce the amount of OID. Now, when we're looking at the first digit for a lateral, let's talk about the big toe, the hallux. Our CR is going to be perpendicular to the IP joint of that big toe. If we're looking at toes 2 through 5, it's going to change a little bit. We're going to put that CR on the PIP of toes 2 through 5. So first toe, IP, 2 through 5, PIP for that central ray, perpendicular beam, no angulation. That will still be on an 8x10 or 10x12 cassette, preferably 8x10 because your toes are very small. I don't really see the need of why you would need to be doing a 10x12. Once again, collimation is key. Toes need that tight collimation to have good quality on that x-ray film. Tabletop always, all toe x-rays are tabletop and gonadal shielding. Now, I will tell you, one thing is really bothering me about this picture right here. Does anyone know why I have a major issue with this picture? This is really bugging me. Anybody point that out?
The anatomy is not centered.
Exactly right. The anatomy is not centered on the cassette, which is very important once again when we're talking about toes. Not only is that collimation vital, but centering on that cassette properly is vital as well, even when we're using digital equipment, because that's a very small body part. It's going to increase the quality of that x-ray if we get it directly on the center of that radiograph. So be very careful on that centering. Plus, you got to do it for lab too, and for competencies. We expect it to be in the middle of that radiograph. But do make sure you put a star on the way you position that foot for laterals. We're talking about toes 1 through 3 versus toes 4 and 5. And that's just showing you once more. That's more proper. That's what I want to see right there, guys. You see that toe is right in the middle of that CR. They've got that central ray perpendicular right to the IP of that big toe. And this is something else you can do right here. Some people will roll up pieces of tape or gauze and actually put it in between the toes to help separate them. That's something else you can do. Will it show up on the x-ray? Sometimes yes. But it's better to have a little bit of that showing up on the x-ray than having the toes superimposed on top of each other. So whatever resource you can grab to separate those toes is going to make that a much more higher quality x-ray. They're using a combination of the rolled up gauze or tape and an actual strip of tape pulling those toes out of the way. So that's where those critical thinking skills come in sometimes. You got to move fast because they're in pain, they might be bleeding, but how do I get those toes separated efficiently and quickly? Because sometimes they don't want to pull those toes out of the way. They're in too much pain. So you got to maybe have someone stand there with them, holding the toes out of the way, or have them hold a piece of tape, pulling their toes out of the way, or whatever you can find. Find ways to separate those toes so they don't superimpose on top of each other. Now here's our evaluation criteria, and this is a nice x-ray of a lateral toe. This is what we want to see, by the way. That toe is completely free of superimposition in a nice, true lateral, centered to our film with that nice, super tight collimation. So we want the digit to be in the true lateral position. It goes without saying, we're looking at a lateral. It needs to be a true lateral. The IP and MTP joints, depending on what toe it is, need to appear open. So not only do obliques show those joints open, but for toes, a lateral also shows those joints very open for us. And that key factor right there, like we've already talked about, we want that digit completely free of superimposition. Don't ever send an x-ray in with those toes overlapping on top of each other unless you've done everything you can. And it's just literally impossible to move those toes out of the way. Most of the time you can get them moved out of the way. Probably what people hate the most about toes is trying to separate those toes. It can be difficult depending on the age of your patient, especially if they have a lot of arthritis in their feet. Their toes are like really, really stiff. But there is a way to get them nicely separated. So use those critical thinking skills, separate those digits, get them in that nice true lateral. Make sure you turn the foot the correct way to reduce that OID, and you'll get a nice true lateral toe x-ray. You do remember, if you wrote this down last time, make sure you write it again. Most of your facilities, once again, when you're doing a 3-view toe x-ray, they're usually going to do an AP foot, then oblique toe, lateral toe. Most facilities you go to will never do just plain AP toes. And I know Harris Health doesn't do that either. Harris Health will always do an AP foot, then oblique toe, then lateral toe. That's part of their protocol here. So I want that to mix you up when you get out there in the clinic and see that. AP toes exist, but Harris Health protocol calls for an AP foot first instead of AP toe. Okay, now let's go to foot. This is what you'll see more commonly. Most of the time, even when the toes are hurt, they'll more often opt for a 3-view foot x-ray because it does show everything, much like a hand shows fingers and hands. So we're talking about the routine views of a foot. We have our AP, oblique, and lateral. And by the way, this is an AP foot. You'll hear some people mistakenly call this a PA foot. This is an AP foot based on what? Anatomical position. Remember anatomical position? We're looking at the top of the feet when we're standing in an anatomical position. This is an AP foot. So we're going to do an AP, oblique, lateral, and special projections, which you'll see at some of the clinics, are what we call AP and lateral weight-bearing feet. What that simply means is basically the patient is standing on top of their feet, putting weight on the feet, and we're taking x-rays of them while they're standing up to evaluate the joint spaces and the pressure on the feet as well. And once again, I just want y'all to look at this. What's wrong with this x-ray? They got that marker upside down again. Don't put your markers like that. Yeah, I'll write that in on your book. I don't want you to make that mistake because we do hang the toes up on our x-rays. Now let's start with our AP foot. Of course, the patient will be supine or seated on the table. We're not going to have them standing for an AP foot. Make sure you remember that. A standing AP foot is its own special projection. They need to be sitting or lying down on the table. We do not want weight on the feet for a regular AP foot. We are going to have them flex the knee, and the main reason we're going to have the patient flex the knee, this is very important, by the way, we want that plantar surface to be as flat on the IR as possible. If we do not flex the knee, we have an issue where the natural curve of the foot may cause some OID of those tarsal bones. So we want that foot as flat as possible. We achieve that by having the patient bend or flexing their knee, putting that foot flat on the IR for us. 40-inch SID. Now for AP feet, we are going to add an angulation, much like the AP toes. It's going to be a 10-degree posterior angulation towards the calcaneus or cephalic angulation towards the head. 10 degrees specifically. There's no range on that. That has to be at 10 degrees. And that's going to enter right at the base of the third metatarsal for a foot. A little bit hard to see, a little bit hard to palpate as well. Basically, you're talking about the mid-surface of the top of the foot when you say base of that third metatarsal. And this picture is a little bit off, but that's pretty close to the base of that third metatarsal. Essentially, if you're at the mid portion of that foot, you're at the base of that third metatarsal. You don't want it to be at the ankle, that'd be too far. You don't want it to be touching the toes, that'd be too far as well. In between the toes and the back of the heel, right in the middle of the foot, will be the base of that third metatarsal. You are going to use an 8x10 or 10x12, and that's important to note because people have different size feet. You have someone with a very large foot, you want to opt for 10x12, a smaller foot, 8x10. Don't try to fit someone with a 13 size foot on an 8x10 or their toes will be hanging off or their heel will be hanging off the back of that film. It does need to be lengthwise, by the way, lengthwise to accommodate the length of the foot. And collimation is going to be important once again, because when it comes to those toes, the more collimation, the better we're going to visualize them instead of leaving that film wide open. Tabletop, you should always do feet tabletop. You do not want to do these actually in the table. You would not do this in the table bucky. That needs to be tabletop. And gonadal shielding, as with everything that we go over. And that would be our AP foot. Probably the part people will forget the most on AP feet is adding that angulation. 10-degree angulation is very important. Why do we add the angulation? That's to create separation amongst the tarsal bones so we can better visualize the tarsal bones individualized. Otherwise, if I didn't add my angle on an AP foot, my tarsal bones will start overlapping each other, and I won't get a nice, beautiful representation of those tarsal bones separated. That's a good thing to write down as well, to separate those tarsal bones. That's why we add the angulation on our AP feet specifically. Okay, so what's our evaluation criteria? We do want the entire foot visualized. When I say entire foot, that means from the tip of the toe all the way to the back of that calcaneus. Toe to heel is the entire foot, not toe to ankle. You'll see a lot of text. They will collimate off the back of the heel. We do want the back of the heel or calcaneus visualized on that x-ray as well. So from the tip of the toes all the way to the tuberosity of the calcaneus, to be specific. We do want the cuneiforms, cuboid, and navicular demonstrated, free of superimposition. How do we achieve that? On an AP foot, we achieve that by that 10-degree angulation that we're putting on that foot. That separates those cuneiforms, cuboid, and navicular, and keeps them from overlapping on top of each other. We want zero rotation of the metatarsals because we're not doing an oblique, we're only doing an AP. And we want the MTP joints to be generally open. Putting that angulation is going to help us achieve that as well on those MTP joints. And of course, our optimal exposure factors, that'd be about a 50 to 60 kVp range on most average feet as far as optimal KVP settings. Most commonly, you'll see about 60 at 2 to 2.5. 60 kVp, 2 to 2.5 mass is the most popular setting on most feet x-rays. You don't need to know the kVp and mass. I'm just telling you if you're interested. You don't have to worry about that yet. That's coming later. And where they have that R there, that's probably the best area to put your marker, by the way, because the way the feet are oriented, the toes, the big toe is often right up here at the corner, and the toes kind of move out of the way as you go towards the pinky toe. So you usually have that little space right there on the right side. Be a nice spot to put your marker. And do make sure you remember, once again, guys, on an AP foot, we can see all three cuneiforms separate. When we talk about the medial and the lateral, they're going to start superimposing each other a little bit. So on AP foot, we can see the medial, intermediate, and lateral cuneiform completely separated. So for the oblique, big star moment here, big star. We always at Harris Health do a medial oblique foot. Always do a medial oblique foot. And once again, just based on the facilities I've been to and visited and seen, I've never seen a lateral oblique foot. I've only ever seen medial oblique. So that would be another case, kind of like with the toes, where only if the doctor specifically ordered lateral oblique would you do it that way. But you're always going to opt for that medial oblique, and that's going to be a 30 to 40 degree medial rotation. 30 to 40 degree medial rotation. We are going to flex the knee, same as we did for the AP, to try to reduce that OID, that natural curvature underneath that plantar surface of the foot. And we're removing our angulation. Please remember that, guys, whether we're talking about toes or feet. When you go from the AP to the oblique, the biggest mistake people make is they forget to take that angulation off of their tube. When you go to medial, we're taking the angulation off. It's a perpendicular beam, and it's entering at the base of that third metatarsal, just like the AP, which is the mid region of that foot. And that's the purpose of doing that oblique is going to open up all the joint spaces in the foot. It gives a nice view of all those open joints from the toes to the calcaneus. 8 by 10 or 10 by 12, same concept, depending on how large that foot is. You're going to opt for the 8 by 10 versus the 10 by 12. That will always be lengthwise to accommodate the top of the toes all the way to the back of that calcaneus. We want the entire foot represented on our obliques. Collimating down to the part, tabletop, always tabletop, and gonadal shielding. And they're still doing it in these pictures. It's driving me nuts. Don't put your markers like that, guys. I'm just going to point that out. Don't put your markers like that. It's upside down. Because we hang the toes up. Don't do that. I don't know why they keep doing that. You'll see right here in this picture that they use a little sponge. Most facilities don't have these, so don't expect to have these on hand. But if they do have a nice little wedge sponge like that, that can help you get that nice 30 to 40 degree oblique. Just rest the foot on the angle of that sponge, and it'll put it exactly how you need it to be. They don't actually have that sponge all the way under the foot. You actually push that in a little further to help achieve that nice oblique that you're looking for. Now, for our evaluation criteria, same thing. And this person really cut this close. But I want you to remember, we do want that entire foot visualized. And we're talking about, once again, the tip of that proximal phalanx all the way to the back of that tuberosity of the calcaneus. We want that entire foot. A lot of techs will cut the back of that heel off. That's not acceptable, though. We need to see the entire calcaneus on there as well. We do want the third to the fifth metatarsals free of superimposition, because they do often overlap. That's why we add that oblique to bring them free of superimposition. A lot of people, as they age, those metatarsals naturally start overlapping on top of each other. That oblique helps us free those of that superimposition. We also want the sinus tarsi open and visualized. Can you see the sinus tarsi without me pointing to it? You know what that is? That little hole right here? That's the sinus tarsi. Should look a nice little circle on those obliques. We want that completely open and visualized. That's another indication that we have a true oblique foot. We want the tuberosity demonstrated at the base of that fifth metatarsal and in profile. Remember I told you guys that's an important piece of anatomy. That's right there, if you remember, the base of that fifth metatarsal, that tuberosity. We want that in profile. That tells us it's a nice true oblique. Entire calcaneus, like I already mentioned. Top of the toes all the way to the back of that heel. Nice open joints. And where you see that R right there, that's a great place to put your marker, just like with the AP we were talking about a minute ago. Look at your foot, you can see all these joint spaces are very open. That's why we do that 40-degree oblique. It's going to open up all those joint spaces very nicely. MTPs, PIPs, DIPs, all the spaces between the tarsals, nicely visualized. So another thing to make sure you write down, we talked about this in the anatomy section. So when we look at our medial oblique feet, changes a little bit. The medial and intermediate cuneiform are superimposed, and the lateral cuneiform is seen by itself. It's another great thing to write down. Oblique foot, medial oblique foot. The medial and intermediate cuneiform superimpose, and the lateral cuneiform is seen alone by itself. We also can see the cuboid very clearly, which is right here. And our navicular, we can see them all actually. Only ones that are superimposed is that medial and intermediate cuneiform. Okay, so for our lateral feet, so I'm going to show you two different laterals here. We're going to start with the mediolateral. The mediolateral foot is the gold standard for lateral feet. The one you want to opt for, if you can, is always the mediolateral foot. We also do a lateromedial, but that would not be the ideal position. The ideal gold standard position for a lateral foot should always be mediolateral, unless it's impossible for the patient to do so. That's going to put the foot in the most true lateral position compared to the opposite position. The other one should be done as a last resort if you just cannot achieve it. What I mean by mediolateral, that means that the lateral surface of the foot is touching the IR and my CR is entering the medial surface. We're following the path of the beam. Beam comes down, hits the medial surface of the foot, exits the lateral surface of the foot. Therefore, it's what we call a mediolateral foot. That's the one you guys learn in lab, where you have the lateral side of the foot on that IR. Now, for lateral feet, it is very, very important that we always dorsiflex the foot. You guys remember what dorsiflex means? If I flex my foot up, you must dorsiflex the foot for a lateral foot. No exceptions, unless the patient just outright refuses. And the reason for that is we do evaluate the ankle joints on lateral feet. Even if we're not doing an ankle in particular, they still evaluate the ankle joint on lateral feet. So we will dorsiflex the foot. Now, one thing you guys probably learn in lab, and correct me if I'm wrong, when you do a lateral foot, you don't exactly put the leg all the way down on the table. You kind of have the leg slightly elevated, yes? Did you guys learn it that way in lab? You know what I'm talking about? You're not going to put the knee lateral on the table. It's going to be slightly elevated in the air. Did you guys learn it that way in lab or no? I know what I'm talking about.
I think in the notes it says something like most people the knee's not going to be flat on the table.
And that's a very important point. And the reason I want to make sure you guys know that, you never want to put the knee completely like lateral on the table. You want to have the knee slightly elevated when you do a lateral foot. And the reason for that is that's going to put the foot in a true lateral. If I relax my knee all the way on the table, the foot obliques. So for a true lateral foot, my knee needs to be, if you look at my screen, kind of halfway between all the way up and all the way on the table, like in between both. I don't want that knee all the way lateral on the table. I want my knee slightly elevated in the air. It doesn't have to be much, but you want it elevated because that will put the foot in an actual true lateral. If you do relax that knee all the way down, the foot will oblique more. So don't make that mistake. As far as, let's see, SID, we're still at 40. We're doing a perpendicular beam, no angulation. That's going to enter at the medial cuneiform. The medial cuneiform. which is essentially the same as the base of the third metatarsal. But technically, that CR would be entering at the medial cuneiform. 8 by 10 or 10 by 12, and this is something you want to put a star on because it shifts a little bit. I'm sorry, never mind. We're still landscape. I was about to say it changed. We're still landscape, 8 by 10 or 10 by 12, based on how large the foot is. Smaller foot, once again, 8 by 10. Larger foot, 10 by 12. Collimating that part very tightly so we can visualize those toes well. And that's also another thing that's really important about making sure that knee is slightly elevated. When you put the foot in a true lateral, the toes naturally fan a little bit, like a fan lateral hands. If my foot is obliqued, if I relax my knee all the way on the table, my foot's obliqued, the toes superimpose, and I can't visualize them separated. It's another reason we want to elevate that knee slightly. Tabletop, as always, with our feet and gonadal shielding. Now, there's a little marker here, guys, because I don't agree with that marker placement. This is not incorrect, but it's more accepted to put your marker towards the dorsal surface of the foot, top of the foot. So above that dorsal surface would be the more generally accepted area for the marker. Even though this is not technically incorrect, it's better accepted to put it towards the dorsal surface above the foot. Just a little note there. And I would say even also, in my personal opinion, they did not collimate this x-ray enough. I would have cut some of this off. Whoops. Whoa, what did I just do? I would cut this off right here, guys. You don't need all that extra light. You can bring that collimation close to the plantar surface of the foot. That's going to better improve your x-ray. And then move that marker up here on the dorsal surface of the foot, closer to it. Now, this is the alternative view here, guys. Once again, this is not the view that you want to do unless you absolutely have no choice. Like, let's say the patient's, the other side of the foot is just in too much pain. They're refusing to position it for you, or the doctor specifically said, I want a lateral medial foot. That's the only reason you would ever opt for doing this view. Whether you do this view or not, though, it still requires the foot to be dorsiflexed to put it in a true lateral. So no matter which side you do, it must be dorsiflexed because they're also going to evaluate that ankle joint alongside the foot bones and toes. Same thing though, once again, I would not recommend putting the marker there. You want your marker up here on the dorsal side. So for evaluation criteria, we of course want the entire foot visualized, same as everything we've already been talking about. Tip of the toes, all the way to the back of that calcaneus, where that calcaneal tuberosity is located. And we do want the tibio-talar joint demonstrated and open. So be careful in your collimation. Don't go so crazy on your collimation. By the way, this is very nicely collimated. Usually you want to see a little bit of light underneath the foot. That's considered acceptable. Very careful in your collimation that you don't chop off the ankle joint. So yes, we're doing a foot, but once again, we do evaluate the ankle joint on our foot x-rays. And that is why, once again, we dorsiflex our foot. We don't want this foot limp and hanging. It must be dorsiflexed up so we do have that tibio-talar joint open so we can evaluate it properly. And we do want all our metatarsals superimposed. That once again tells us that we have true lateral and our optimal exposure factors. Key to those laterals, though, once again, make sure that foot is dorsiflexed so we can look at that tibio-talar joint open. You'll see a lot of lazy techs out there. They won't dorsiflex the foot. They think it doesn't matter. Guarantee the radiologist is writing them off as a very crappy technologist. Don't be the crappy technologist. Dorsiflex the foot and send in nice foot x-rays. It does make a difference. And you're saving yourself time. They may opt for not ordering ankle x-rays if they can see it nicely on that view right there. If you send a limp foot in, they're probably going to order a separate ankle series to evaluate the ankle joint. Been there, done that. Trust me. Okay, and this is going to be our special views right here. So certain clinics, very rarely at the hospital, but certain clinics will order what we call weight-bearing AP and lateral feet. By the way, make notes, it's only AP and lateral. We don't do oblique weight bearings. We only do APs and laterals. So essentially, this is just the same as having the patient just stand up and taking foot x-rays. So when we do the AP, our angulation does change a little bit. We add a little bit more of a sharper angle. Our central ray will be a 15-degree angulation towards the heels or calcaneus, and our CR is going to be to the base of the metatarsals in between both feet, as you see right here. So my CR is where I'm putting my cursor in between the feet at the level of the base of the metatarsals. So essentially that horizontal line, I want that to line up at the base of my metatarsals. I want the direct middle of my crosshair in between both feet as the patient standing in the middle of that cassette. For the lateral, I want a horizontal cross table beam. You see right here, they're standing on a little platform against the wall bucky. It does not have to be the wall bucky, by the way. That can be a free cassette cross table. We're going to put that central ray in the same location as we would for a regular lateral, which is right on the cuneiforms. The only difference is we're shooting cross table because once again, we're evaluating with the patient standing up, putting weight on that foot, seeing how they can handle weight on that foot and evaluate it for injury. So this would be a cross table horizontal beam for the lateral. And by the way, make notes, for AP, we do both feet side by side. For lateral, we only do one foot. Obviously, we could not do both feet in a lateral wide and superimpose on top of each other. So we do them one at a time. Even though we evaluate both feet on the lateral, by the way. Don't mistake me from what I said there. We still look at both feet in laterals, but they're separate x-rays. AP, they're both on one x-ray, side by side. And this would not be a routine view. This would only be specially ordered by a radiologist, special projection. Put a star on that angulation, by the way. It's an easy mistake to make. Regular AP feet, it's 10 degrees. AP weight bearing, it's 15 degrees. Does change slightly. For our evaluation criteria of the AP bilateral, we want both bilateral feet demonstrated. The phalanges and MTs not rotated. That's talking about the MTP joints, by the way. And there's actually something really wrong with this x-ray. Where's my QA eyes? Where's my quality assurance techs, my future quality assurance techs? What's wrong with that x-ray based on what we learned about feet?
The heels are cut off?
The heels are cut off. Thank you. You are correct. We do want to see the entire foot demonstrated, both feet, as a matter of fact. This is what a lot of techs will do. That's a big mistake, is they'll cut the heels off on all their foot x-rays. Don't do that. We do need to see the calcaneus on those x-rays as well.
Mr. Donahue, wouldn't you put both markers in there, though? Like left and right?
It's not required, but some techs do that, yes. You don't have to, though. So whoever DH is, I don't know who DH is, but they did not do that x-ray correctly. They cut the heels off. Don't be that tech. Whoops. And for the weight-bearing lateral, we once again want the entire foot demonstrated. They cut it very close there. They almost cut the heel off. They got it all on there. And we want the plantar surfaces of the metatarsal superimposed, the talotibial joint included and open. And what's nice about the weight-bearing, we don't have to dorsiflex the foot. Why? When we stand up and put weight on our foot, the foot naturally dorsiflexes itself. Same thing as dorsiflexing the foot. We're just standing on it. But we are looking for that nice open joint right there, that tibio-talar joint or ankle joint. And one thing that you can always tell that this is a weight-bearing foot, by the way, if I was to show you one side by side with a regular lateral foot, you guys see right here on the bottom of the foot, that line going across. On a weight-bearing foot, you'll always see the surface that the patient's standing on. That's a key indication that you're looking at a weight-bearing foot. See what I'm pointing to? There's a nice, prominent horizontal line going across that shows the surface they're standing on. But on top of that, most weight-bearing feet, even though you didn't see it on the previous image either, they'll usually put a marker that says weight-bearing feet. That's another indication as well. They'll say AP weight-bearing, lateral weight-bearing. In fact, they're supposed to have those, at least at Harris Health. Okay, let's go now to the calcaneus and the ankle. Calcaneus and the ankle. So for calcaneus, we have two routine projections, no special projections for calcaneus. Our routine are going to be the plantadorsal axial and the lateral. And for ankle, we have the AP, mortise, 45-degree oblique, and lateral as our routines. And for our special projections of the ankle, we're going to have the stress view ankles. Stress views would be the special. We are going to start with the calcaneus. And once again, the routine for a calcaneus is going to be the plantadorsal axial and the lateral. No special projections for ankle x-ray. I'm sorry, for calcaneus x-rays. Now, I will say this view right here is probably the one everyone hates the most this chapter. If you've done it in lab, you probably know what I'm talking about. That's the one people hate to do. It's a very sharp angle. Still got to mess that tube and get it to be at 40-inch SID. Make sure everything's lined up properly. This one right here, this is the one I recommend to you if you're going to practice in lab. I would practice this position with the person that you're paired up with in lab because everyone's foot's shaped differently. I would practice that position very, very specifically with your partner to see exactly where you need to put your tube because it tends to throw people off a lot once they add that angle. You're trying to center on the foot and center on the cassette, and that does vary depending on your patient. You use a lot of critical thinking to get that correct. So I would definitely practice that view. That one constantly trips people up in lab. That's the one we're going to start with right here. So this is our plantadorsal axial calcaneus. That is the entire name, by the way. And remember, way back to first semester, when you see that magic word axial, that means what am I doing? I'm adding an angle to my tube. Anytime I say that word axial, it means I'm angling my tube. Patients should always be supine or seated on the table. They would not do this standing up. It'd be impossible to do this standing up, as a matter of fact. We're going to have the patient extend their legs straight out and dorsiflex the foot as much as possible, preferably to where the toes are perpendicular to the cassette. We want that foot to be straight up, completely straight up, toes perpendicular. That's key to getting that position correct. SID will be 40 inches, and the angulation will be a sharp 40-degree cephalic angle entering at the plantar surface at the level of the base of the third metatarsal. Now, base of the third metatarsal, you can't palpate that on the foot. So same concept as when we're doing our regular AP foot, guys. If you put your crosshair right in the middle of the plantar surface of the foot, which you can see right here, hold that crosshair right in the middle of the bottom of the foot, that is the base of that third metatarsal. So about halfway from the tip of the toes to the bottom of that heel will be that base of that third metatarsal. I'm going to be using an 8x10 or 10x12. That varies once again based on whether I have a large or small foot. And this must always be done tabletop. I would never do this at a table. It must always be done tabletop on a free cassette. And I'm using that gonadal shielding. Now, be careful when you do this in lab, guys, for your test outs. Probably the biggest mistake I see is not necessarily the angle. I feel like people get the angle quite well because it's a very sharp angle, 40-degree angle. But what people mess up on is they will either center the foot and not the cassette, or they'll center the cassette and not the foot, and then they won't achieve the 40-inch SID. Keep in mind, when you add an angulation to your tube, your SID changes. It either increases or becomes closer. So always check that tape measure as you're adjusting your tube for those angles to make sure you're still at 40 inches. Once you got that 40-inch SID, at that point, go ahead and center to the part and to the cassette to not throw off your 40 inches. You might have to double check it back and forth a few times, but I'm telling you that because I've seen people struggle in this position for a long time. It always messes people up because they'll get everything good, but they'll forget the 40 inches. Or they'll get the 40 inches and forget the angle. Or they'll get the angle and forget the center. This one position has a lot of pieces going into it. That's why I said if you can practice on any position more than the others, that's the one you want to practice with your partner most because that's the one that tends to mess people up the most as far as getting everything in just the right spot. So be careful on that x-ray. Don't overthink it. People tend to overthink it too much. a lot of pieces to it, but it's still straightforward. Put it right where you need it to be. Check for that 40-inch SID. Oh, by the way, this little note here where it says CR should emerge posterior to the malleoli. One way you can check if you're centered correctly is if you look at your horizontal crosshair, see right here where I'm putting my cursor, that lines up with your malleoli. You're centered to the foot correctly. See right here? If I have my crosshair right here, my horizontal line, if it's touching my malleoli, that means I'm centered in the correct spot on the foot right here. So that's a way to double check yourself a little bit. Okay, so for my evaluation criteria, of course, I'm doing a calcaneus x-ray. Therefore, what do I want? I want that entire calcaneus visualized. And that's talking about from the joint space all the way to the calcaneal tuberosity down here. Talocalcaneal joint all the way to the calcaneal tuberosity. No rotation, that is very important. That's why I want that foot completely dorsiflex with the toes straight up in the air, toes perpendicular to my film. And optimal exposure factors are going to play a large part of this x-ray because if I don't set correct exposure factors on a calcaneus, it becomes very black like the toes. It can actually get burnt out quite easy. On the same subject, I want that nice, tight collimation on that calcaneus. I'm talking about one tarsal bone here. I'm not interested in the whole foot. Much like the toes, it's a small bone. I want it very tightly collimated to help it really jump out on my film and be very nice, top quality. So get that nice boning detail like you see right here. By the way, this is such a great radiograph. Does anybody remember what this is right here? That's a specific part of my calcaneus. One of those words I love. One of those fun words.
Sustentaculum tali?
Very good. Sustentaculum tali. Sustentaculum tali. Over here is another piece of anatomy that's easy to identify. Does anybody want to wager a guess what this is?
Also tuberosity.
That's a common guess there, but actually it's not. It kind of looks like it, but it's actually not. This is actually, it's the fibula.
Lateral malleolus?
This would be the lateral malleolus right here. That's the fibula. This is the lateral malleolus. It looks like that tuberosity, but don't let that fool you. That's the lateral malleolus. The sustentaculum tali is that little protrusion there. Calcaneal tuberosity down here. Lateral malleolus. And even though it's hard to see, the talocalcaneal joint is another piece of anatomy that we can label on these. Talocalcaneal joint is right here. You can see it a lot better on some of the other x-rays, but that talocalcaneal joint would be in that spot right there. Okay, so for our lateral calcaneus, so we are going to take that angulation off. This is going to be a perpendicular beam. We do want to put that leg and foot in a nice true lateral position. You would go ahead and position the foot for this x-ray, by the way, the same way you would for a normal lateral foot. The only difference is we're going to be putting our central ray in a different spot and collimating only to the calcaneus. So put that leg and foot in the exact same way you would do a lateral foot. We're just going to center differently. We're going to put a nice dorsiflex on that foot. Why? Because just like with the lateral foot, just like a lateral ankle, they're always looking at that ankle joint. And we want to see it nice and open, even on a lateral calcaneus. So for my central ray, it is going to be perpendicular. So instead of like a regular lateral foot, I'm going to be putting my CR 1 inch inferior to that medial malleolus. Therefore, I'm going to have to palpate on my patient's foot where that medial malleolus is, put 2 fingers down, go 1 inch inferior to that medial malleolus. I'm going to be on a nice 8x10 or 10x12. I would say on this x-ray in particular, you can usually opt for an 8x10 on everybody because we're only looking at the calcaneus. I've never seen a heel so large it would not fit on an 8x10. So even though it gives you the choice of 2, 8x10 would be one that would work for all your calcaneus x-rays. Collimate down to that part, I'm looking at a single tarsal bone. Tarsal bone in question is that calcaneal bone. Collimate down just to that part so it gives you a nice, beautiful visualization. Tabletop should never be done in the bucky. Always should be done tabletop and gonadal shielding. Make sure that foot is in a nice true lateral position. How do I do that? I dorsiflex that foot. I make sure I don't relax my knee all the way down, just like a lateral foot. It's going to put that heel in a nice, true, profiled lateral position. Just make sure you put that CR 1 inch inferior to that medial malleolus. A lot of people make the mistake of putting their CR directly on the malleolus. You want to be 1 inch inferior to that medial malleolus. So make sure you have that central ray going through that calcaneus. If you put it directly on the medial malleolus, you're actually going to be penetrating through the fibula. It's actually going to burn out your calcaneus. Now, same subject here. This person did not center this foot correctly in this cassette. If you see the middle of the cassette's right here, they're not even lined up to their cassette properly. Make sure you put that part directly in the middle of that cassette and line your crosshairs up with your cassette. It is not centered correctly. By the way, this little bomb here, I forgot to mention this. You see how this picture has his foot on a sponge? Don't do that. That's a bad idea. It's actually going to oblique your foot. It's not going to put your calcaneus in a true lateral. Do not do this. It's a bad idea. They're doing that to help support the patient's foot for pain purposes, but you would not want to do that. It's actually going to bring the quality of your x-ray down because you're actually going to oblique the parts. And for our evaluation criteria here, guys, we of course want the entire calcaneus visualized, but also for a calcaneus lateral, we also want to see the entire talus visualized. So we're looking at the calcaneus and the talus fully visualized. We want that talotibial joint open. Once again, how do we achieve that? I'm saying it over and over again so it sticks. We achieve that talotibial joint open by dorsiflexing the foot, dorsiflexing that foot. Sinus tarsi and talocalcaneal joint are also going to be open. Sinus tarsi is that little hole there. Talocalcaneal joint is this line going across right here, nice and open. That's the connection between the talus and the calcaneus. The calcaneus should be in profile in a true lateral with no rotation. We achieve that by putting the foot in a true lateral with dorsiflexion. And of course, our optimal exposure factor and nice tight collimation. Very tight collimation. And as you finish writing that one, go ahead and take a 5-minute break and get me another water real quick. We will pick back up at 2:07. 2:07. All right, everybody, let's start heading on back. Keep moving forward here. Okay, so we're going to go ahead and move forward to our ankle projections next.
I'm sorry to interrupt you. Amy is trying to reconnect. Oh, she's here.
I'm back. I was able to do it. Thank you. I had lost connection.
It's okay. All right, we're good to go. Let's keep moving here. All right, so for our ankle routine x-rays, you'll see there are 4 different views that follow the routine, but not all 4 of these will always be performed. I'll tell you what I'm talking about here in a second. So for routine, we have just a typical AP. We have the AP Mortise, or 45-degree oblique, and a lateral. Now you will notice there's an or in between Mortise and 45. The reason for that is the physician, depending on what they want to see, will opt for a normal 45-degree oblique or a specific Mortise view. They will never do both. It'll always be one or the other. So even though all 4 of those fall under routine, they will only do 3 of those 4, depending on what the doctor actually wants to visualize. So we're going to start with our AP. So for AP ankle, as with most of these foot and toe x-rays we've talked about, they're going to be supine, lying down, or seated on a table. Now, it is extraordinarily vital when we do an ankle x-ray, whether we're talking about an AP, Mortise, oblique, or lateral, that foot is dorsiflexed as much as possible. So it changes a little bit from the feet. When the feet and toes, it was only the laterals, same with calcaneus. We want the ankle to always be dorsiflexed on all the views. That means I want those toes to be as perpendicular as possible with the cassette. I would say even this picture right here, this patient did not dorsiflex the foot enough. I would have actually dorsiflexed that a little bit further so that those toes are perpendicular to the film. The more I dorsiflex that foot, the more open that ankle joint is going to be. And that's why I'm doing the x-ray. I'm evaluating that ankle joint specifically. So you got to dorsiflex that foot. So you're going to have them extend the foot, have that foot in a true AP, but we're dorsiflexing the foot up with the toes perpendicular to the film. Our CR for all of our ankle x-rays will have no angulation. Our CR for all of our ankle x-rays will have no angulation. It's always going to be perpendicular for ankle views. It's going to enter directly in between both malleoli, essentially right on top of our ankle joints. So when you dorsiflex the foot, there'll be a little bit of a crease on the foot right here. Where I'm putting my cursor. That's where you want your crosshair to be. Or if you want to palpate both malleoli to make sure that your horizontal line is lining up with them, that's also directly in the middle on that ankle joint. You are going to use an 8x10 or 10x12 landscape. Same concept, depends on how large the patient's foot and or ankle is. Commenting down to the part, we're doing all of these tabletop, just like everything else we've hit so far. You always want to make sure your ankle x-rays are tabletop. Do not do these in the bucky, in the table. And of course, our gonadal shielding. Key for all your ankle x-rays, though, guys, is you must dorsiflex that foot. You've got to open up that ankle joint. If you send a doctor an x-ray with a closed ankle joint, they're going to get really upset with you. They always want that ankle joint to be open. And that means that a lot of times, yes, the patient will be in pain. They must dorsiflex that foot. Even if you got to go out there and help them flex it, it's got to be done. Can't send the doctor a closed ankle joint. They won't accept it. Now, for my AP ankles, what do I want to see? I do want to see the distal 1/3 of the tibia and fibula. Why? Because, well, the ankle joint's made up of what? Tib, fib, and talus. We want the distal 1/3 of that tibia and fibula demonstrated and the proximal half of the metatarsals included, even though we probably won't see the metatarsals. Let's talk about this right here, by the way. The metatarsals are basically superimposed on top of each other, as they should be, if I have that foot dorsiflexed properly. And here's the thing. If your ankle does not look like this, like if you can clearly make out the metatarsals, what's that telling you? That's telling you didn't flex the foot enough. That's telling doctor you didn't flex the foot enough, because not only is the ankle joint going to be closed, you're also going to see those metatarsals. So if you try to pass something and say, oh, I flexed the foot, and you're visualizing all those metatarsals, they're going to be able to tell really quickly that you did not flex the foot. So make sure you're dorsiflexing that foot. It's two indications: open joints and superimposed metatarsals right here. We must see the medial and superior aspect of the ankle joint open. Let's talk about this section right here, by the way, right underneath the tibia, and this section right here by that medial malleolus. We're not concerned with this area right here by the fibula for AP. We're only concerned with the superior and medial aspect of that ankle joint being open on an AP view. So we will see that fibula superimposing that lateral aspect of the ankle joint just a little bit. That's the way it's supposed to look. Okay, so we're going to go to the AP Mortise view. So for the AP Mortise, we're still going to have the patient essentially in the same position. We want them lying down or sitting up. We want that leg extended with that foot dorsiflexed, but we are going to rotate the ankle 15 to 20 degrees. Now make sure you write down these obliquities because they change between the two different obliques we're talking about here. For a Mortise view specifically, it's a slight 15 to 20 degree medial oblique. It's a medial oblique. Essentially what we're doing with a 15 to 20 degree oblique is we're making that intermalleolar line parallel to the IR. And even though it says dorsiflex foot if possible, I'm going to say you must dorsiflex that foot because if you do not, you're not going to open up the Mortise joint properly. The doctor's not going to accept that. So make sure you're still dorsiflexing that foot. CR is still going to be perpendicular midway between both malleoli, so you're still directly on that ankle joint the same as the AP. Really, the only thing you're doing differently on this view is you're slightly rotating that foot 15 to 20 degrees. Very slight medial oblique to open up that entire Mortise joint. 8x10 or 10x12 landscape, collimating down to that part properly, still tabletop, and still using our gonadal shielding. It's a very slight medial oblique, and that's always going to be a medial oblique, by the way. You would not ever do a lateral oblique for ankles. No matter what type of oblique, by the way. It's always medial obliques, period. In fact, a lateral oblique ankle does not exist. Just remember that 15 to 20 degrees. It's going to change when we get to the next one. So what are we looking for? Well, we want that entire ankle Mortise joint open. What am I talking about? I'm talking about the area close to that bottom of the fibula, which is right here, all the way up around that entire ankle joint is completely open. Remember on the AP, the fibula was actually superimposing the lateral portion of that ankle joint. But in a Mortise view, I can see the lateral portion, superior portion, and lateral portion of that joint space completely open. Very nice. I still want the distal 1/3 of the tibia and fibula demonstrated, which is this portion right here. And that proximal half of the metatarsals should be visualized, which you see down here. Now on this oblique, they're not going to be superimposed on each other like they were for the AP. We'll see them separated. That is acceptable. We're still dorsiflexing that foot. Main thing we're looking for, though, on this Mortise view is what we see right here. We're about to draw this line. We have this nice, beautiful open joint space right here, all the way around. The entire Mortise joint is open. So the other oblique that we may get asked to do by the doctor is just the traditional 45-degree oblique. Still a medial rotation, by the way. Whether it's Mortise or 45, it's a medial rotation. We still have the patient flat on the table, supine or sitting up. We still have that leg extended, and we still have that foot dorsiflexed. It must still be dorsiflexed. The only thing we're doing differently this time is it's a much sharper oblique. It's a complete 45-degree oblique compared to the one we just did. 40-inch SID, we're still perpendicular to the midway point of the malleoli, which is directly on that ankle joint. We're still on an 8x10 or 10x12 landscape set. Collimating down to our part, we're still tabletop as well. And as with everything, we must use that gonadal shielding always. Only difference here, once again, though, is we're just simply rotating that foot even sharper to a nice 45-degree oblique instead of that slight oblique that we had on the Mortise. So it's at 15 versus 45-degree oblique. Know the difference there. By the way, it's in the name, guys. If you don't know how much you need to oblique the foot for a 45-degree oblique, guess what? The name says AP 45-degree oblique. You can't miss it. It's in the name. Don't put 15 degrees for a 45-degree oblique ankle. I can't help you more than that. If it's not the 45-degree oblique ankle, the only other oblique for an ankle would be that 15-degree Mortise view. So what are we looking for on this one? Well, we want the distal tibiofibular joint to be open. That's the key difference, by the way. For a 45-degree oblique, you're going to look for this joint right here, guys. This distal tibiofibular joint should be opened. That's the key indication that you are looking at a 45-degree oblique. Can't see what I'm talking about? That's this joint right here. That's the view that will open that joint specifically up. We still want that distal 1/3 of the tibia and fibula demonstrated, and those proximal metatarsals down here demonstrated as well, and our optimal exposure factors. So remember, the Mortise view opens up the entire Mortise joint. The 45-degree oblique view opens up the distal tibiofibular joint. That's the clear difference between those two obliques. We do not open the entire Mortise joint for a 45-degree oblique. It closes right here. Only looking at that joint right there, that distal tibiofibular joint opens. Okay, so for our lateral ankle, much like the foot, there are two different ways to do it. The gold standard, the way it's the most commonly accepted and the best way to do it is the mediolateral, just like the foot. But if the patient refused this position or it was impossible to acquire, you can do the alternate lateromedial. Whether we're doing this view or this view, they must dorsiflex the foot because we're still doing an ankle. But really, all those laterals that we went over, they must be dorsiflexed. So for our lateral ankles, we're going to be at a 40-inch SID. I thought I had my chart on here. I didn't get my chart on this one. We're going to be using a perpendicular central ray directly on the medial malleolus. Now, that's going to be a little bit different than we talked about with that lateral calcaneus, because lateral calcaneus, we were an inch below the medial malleolus. But for a lateral ankle, we are directly on the medial malleolus. Dorsiflexed foot, purpose of dorsiflexing that foot in the lateral, we're opening up that ankle joint, that tibiotalar joint. 40-inch SID, we're still tabletop. 10x12 versus 8x10 landscape. Gonadal shielding, just like everything else we've talked about. We want to make sure it's a nice true lateral with that joint space opened at the tibiotalar joint. Once again, this is the one that you want to do. Don't do this one unless you have no other choice. And for our evaluation criteria, we do want the entire talus and calcaneus visualized. Talus right here, calcaneus right here. And we do want the lateral malleolus superimposed over the posterior half of the tibia. Posterior half of the tibia. What's that talking about? I'm looking at my tibia right here. If I cut it down the middle, I have the anterior surface right here, posterior surface right here. I want my fibula to be superimposed over this posterior surface of the tibia. We draw it for you. So we see right here. Here's my fibula. Here is my tibia. As you can see, the fibula is superimposed over the posterior edge of that tibia. It tells me I have a nice true lateral ankle. And of course, I want this nice open joint down here. How do I achieve that? I've said it a million times. I achieve that by dorsiflexing my foot. We must dorsiflex the foot to open up that joint. Or you have a grumpy radiologist. Okay, and then our two special views. These are special views for the ankle specifically. They're what we call the AP stress views. We have an inversion stress view and an eversion stress view. These are both going to be perpendicular exams, no angulation on our CRs, 40-inch SID, on the same cassette sizes as everything else we've talked about, still tabletop, still centered directly on the ankle joint between both malleoli, but there's one huge difference on these x-rays, and I believe I brought it up earlier in the anatomy section. Does anyone remember what I said specifically about stress views that you as a tech need to make sure you remember? Does anybody remember?
Never do them. The radiologist has to come in and do them.
You are correct. Either the radiologist or the ordering physician, like the ortho doctor, has to come in and position for these x-rays. You will never position for stress view ankles. You can get in very big trouble for that. You can actually lose your job over that. If ever a stress view x-ray comes into your department, make sure you let your technologist know and make sure that you're never put in the position where you're actually positioning for this x-ray because it will not be allowed. The doctor themselves must position for this specific x-ray. Now, when we do an inversion stress, we're rotating the foot medially. When we do an eversion stress, we're rotating the foot laterally. And essentially, it's just what the name says. They're putting stress on the ankle joint to further evaluate it for injury. Mostly if there's like a pulled tendon or ligament, that's usually what they're evaluating on stress views. But once again, you as a tech, you as a student will never position for these. You'll only position the tube, center it. The doctor will actually position the part for you. Don't ever put your hands on a stress view. You lose your job and get in big trouble for that. Now, for our evaluation criteria, this is what they would look like, by the way. This would be the medial rotation versus the lateral rotation, inversion versus inversion. You still want the distal aspect of that tibia and fibula demonstrated. Ankle joint must simply be on the center of the collimation field. And of course, positioning will be key, but you're not going to be doing the positioning. That'll be something the doctor does. And actually, what you can see right here, this is the doctor's hands with lead gloves on. That's why it looks all white. They're using lead gloves to protect their hands from the radiation. But they're going to put stress on that ankle joint to get some further evaluation to see what's going on there. That'd be our AP stress ankle views. And I think that's a good stopping point for today because you all look like you're about in a coma out there. So let's see, I only got 5 minutes left. We'll stop right there, guys. So we will pick back up on Wednesday with the tib-fib x-rays, which is only 2 positions. And then our final knee positions will be the last ones we go over before we get ready for our test. Are there any questions about what we went over today? All right, you guys look like you need some coffee or something. Y'all like The Walking Dead today. It's okay. We'll blame it on Monday, right? Monday and the cold weather. I think that's a good excuse. That's all right. All right, guys, if you have any questions, please let me know. I will send you the PowerPoint thus